So good afternoon and welcome to this showcase from the Applied Research Collaboration in the East Midlands. That's part of the National Institute of Health Research, or NIHR. And today we're going to be presenting one of the main themes of work within our Applied Research Collaboration, which is around building community resilience and enabling independence, or catchily titled BICRE for short. This is really a programme of work which is focused around work that takes place predominantly outside of hospitals in the community, and predominantly is focused on either protecting people from declining health, what we would describe as resilience, or enabling them to recover after they've had an episode of ill health, so enabling them to be independent. I'm going to be speaking with a number of colleagues. They're on screen just now, and I'll introduce them and they can give you a quick wave as I introduce them. Then they're going to go blank and I will lead off the first part of the session. So we have Rebecca Fisher, Nikki Chilaria, Lal Russell, Neera Sirawardena, and I'm Adam Gordon. Just a few bits of housekeeping before I start speaking. This is the webinar version of Zoom, so you can't interact directly with us by speaking to us, but you can use the chat box and the question and answer box to speak with us as the presentations go on. We will be allowing time between 10 and 15 minutes at the end of the presentation to have a discussion. So please do put your comments, questions, provocative thoughts in the chat, and we'll try to return to them at the end when we are having the discussion, so that we can address any concerns, uncertainties, or thoughts that you may have. In addition to that, we would encourage you to share what you're seeing here today. Please do feel free to share on social media. The ARC is active on Twitter. We are not using a hashtag here today, but if you do tweet, do feel free to include the ARC or me or any of the other speakers in your tweet, just so that we can participate in the conversation and also share and retweet your thoughts about what we've been discussing. So what I want to do now is just outline briefly what's involved in the BICRE theme. And there are three main areas, and we'll be covering a little bit from each of these sub-themes here today. We have a programme around care homes and rehabilitation for older people with frailty, and I am the academic lead for that programme of work. We have a programme of work around stroke rehabilitation, and Rebecca Fisher, who you'll be hearing from shortly, is the lead for that portion of work. And then finally, we have a section focused around emergency services, particularly ambulance services for older people with frailty. And that sub-theme is led by Professor Neera Sirawardena from Lincoln, and he will speak to you later on during the programme here. So what I want to do now is just start off by talking a little bit about the care homes and rehabilitation for older people with frailty. And there are a whole host of researchers that are involved in supporting this work. So we're really fortunate to collaborate with some real leaders in their fields as we're doing this work, all based here in the East Midlands, but based across the East Midlands, from Derbyshire down to Leicestershire and across to Lincolnshire. And these are all the colleagues that I could find by Googling them when I put this slide together this morning. So if you're not included, please don't be offended. It's just because you didn't come up in Google when I did my quick search. But I just wanted to make sure that this was recognised to be a team endeavour with lots of people working to make sense of what's going on out there in the community. So there have been 5 studies planned as this part of the sub-theme. The first of these is the care home COVID study, looking at how care homes coped and responded to the early parts of the COVID pandemic. The next one has been the Falls in Care Homes implementation study, looking at how we can implement evidence-based approaches to falls prevention in care homes. We have one study around long COVID, and that's particularly interested in how rurality, living in the countryside, affects your access to long COVID services, and whether there are particular things we can do when we're planning those types of services that can make a difference and help ensure that everybody gets the best care possible. We have a piece of work that's just starting around continuous glucose monitoring and deprescribing in care homes. And this uses a new type of glucose monitor that can record your blood sugar levels around the clock. And it uses this to help primary care staff think really critically about whether they can stop some diabetic drugs which might be doing more harm than good, so making care safer and reducing the burden of drugs for older people who are in care homes. And then finally, we're doing a piece of work with the Office of National Statistics, looking at people who have become disabled during the COVID-19 pandemic and seeing whether we can learn any lessons from the policy decisions that were made and the impact those have had upon people's independence and their subsequent disability. So all of these are part of this sub-theme. The last three studies, the long COVID through to the new onset disability study, are in their very early phases. And I would love to come back and share some more about those with you at a future ARC showcase. But for today, I'm just going to tell you briefly about the first two studies, the Care Homes COVID study and the Falls and Care Homes implementation study, just to give you a flavour of some of the exciting work that we've been able to undertake here within the ARC. So care homes and COVID, why did we focus on this as an area of concern? Well, you know, everybody knows that care homes were desperately, badly affected by COVID during the first wave of the COVID pandemic. So the first wave was between March and June 2020. And for the 6 months between December 2019 and the 12th of June 2020, we saw 29,393 excess deaths. So that's more deaths than predicted in the care home sector, of which the vast majority were directly caused by COVID-19. And this means that during that first wave of the COVID pandemic, about half of all deaths that were recorded were in care homes. So it was a really devastating time for the staff in the care home sector, for the residents and for their families. And that first wave was very awful. These are deaths from COVID-19 according to Care Quality Commission data. You can see how many deaths there were during that first wave, which is the blue line starting in the second quarter of 2020. But you can also see that there was a very significant spike of deaths in the beginning of 2021, shown with the orange line, again showing that the pandemic just didn't go away after June. It kept coming back and kept doing harm to care home residents and also to their families and the staff that looked after them. So we set out to ask this question: what can we learn from how care homes were and were not supported during the first two waves of the COVID pandemic in order to support future practice? So this is not about looking for fault or picking fault for fault's sake. Rather, it's about learning lessons that could help us to work more constructively with care homes in the future. The work took the form of detailed interviews, and we did multiple interviews with 10 care home managers from across all parts of the East Midlands, so from Derbyshire, Nottinghamshire, Leicestershire, Lincolnshire and Northamptonshire during both waves 1 and 2. And we had really long and detailed and often difficult conversations with them about what their experience had been. And then we did a detailed analysis of the interview transcripts, and we looked at this from an organisational perspective, which is to say we really looked at how the care homes as organisations had coped with the pandemic, and we had a particular focus on how they interacted with other organisations and other groups outside of the care home, because we knew that was important to how care was delivered during the COVID pandemic. The first article from the first wave has been published. I put the title of the article at the top there. If you take a picture of that QR code on your mobile phone, then you'll be able to go directly to the article. And the main findings here were really around how much care homes had to work around the guidance that was given to them by government. So we work on the assumption that the government advice is very logical and sensible, and all care homes should really have to do is to follow that. But in reality, we saw a very different picture. For a start, the government were very slow off the mark with their guidance, and we didn't really see any sort of detailed government guidance until the middle of April with regard to managing the COVID-19 COVID-19 pandemic in care homes. And that meant that there was a month when care homes had to feel their own way. And we saw some excellent examples of care homes being really ahead of the curve, including, for example, care homes which made decisions to lock down even before the British government had declared a pandemic, just on the basis of the news coming from China and Italy. So really good evidence of care homes doing proactive, independent decision-making that was ahead of the curve. Then when the guidance did come in, there was a sense that it often didn't suit the care home setting as well as we might have hoped. And so there was evidence of managers having to think really critically about the guidance they were given, making sure that they delivered their care in a way that was safe for residents and that they picked the good and workable parts out of the guidance, but that they also found ways to work around the parts that didn't work. For example, around particular structures of testing protocols, which came in during May and June. There was a lot of evidence about the importance of charities, community in the third sector. So care homes often struggled to get help from the NHS or from local authorities during the first wave. And to a certain extent, that's understandable. These external organisations really were still getting to grips with the pandemic for themselves. But in the absence of that type of support, they went out and found help from other organisations. And these were, for example, religious groups, Rotary groups, and third sector organisations like hospices and charities. And really, it was the ability to do these things that enabled care homes to be, and I'll just duck my head down there, resilient against the pandemic. So the real strength came from care homes thinking flexibly and laterally. We haven't yet published a paper from Wave 2. We're just in the process of writing the final version from that. But Wave 2 was really a very different picture. The inspections, which had been cancelled early in the first wave of the pandemic, were resumed. And this came with a lot of other external scrutiny from public health and NHS bodies. Suddenly, from having no government guidance, they found they were getting new guidelines every 2 or 3 weeks. And this was rapidly changing, often contradicted each other, and led to quite a confusing situation. A lot of that informal support that I described before from charities, communities, religious organisations and third sector organisations withdrew because life went back to normal and people didn't have as much spare time to help care homes. And media coverage became much more hostile. So care home staff went from being angels during the first wave of the pandemic, often to being blamed for deaths and or blamed for the policies that were implemented in response to deaths, for example, lockdown and visiting policies. And so they found themselves navigating a very different set of scenarios. But we do have really quite strong evidence, again, about how they work flexibly and really independently of external organisations, and how much expertise and nuance of thought they showed when navigating these really difficult pathways. So taking those findings together from Wave 1 and Wave 2, what do we want to do with that to make a difference? Well, we want to produce some really accessible and straightforward guidance for NHS staff and for external staff that have to work with care homes, so that they can ask the right questions when they go to work with care homes, so that they can harness that expertise and make the most of the expertise that the care home sector have. Secondly, we want to produce some standard questions that care homes might want to ask visiting NHS staff or staff from other organisations, so that they can really understand what external staff are looking for and how to meet them in the middle. And really, all of this is designed to foster more collaborative ways of working. And we hope to have all of those resources ready and completed by the end of the summer. And we look forward to sharing them through the ARC website and through our Twitter feed. So I'll just briefly talk about the Falls and Care Homes project before I hand over to my colleagues and the other sub-themes. So Falls and Care Homes leads on from a really quite large multi-centre randomised controlled trial that was conducted in care homes and funded by the National Institute of Health Research. If you want to learn more about that, you can click on the QR code in the top right-hand corner, and that will take you to an open access BMJ paper. But this was the largest ever randomised controlled trial conducted in UK care homes, 1,657 residents, 84 care homes, and it tested an approach to falls prevention called Action Falls, which was a combination of education and care planning and care pathways to enable care home staff to make the right decisions after a resident has fallen. And what we showed was it was a really quite significant reduction in the rate of falls in care homes. There was no increase in dependency associated with this. So people maintained their independence, even though they were less likely to fall. And the intervention was cost effective. And so it was the sort of thing that makes sense within the National Institute of Health Research. Now, in the past, that type of randomized controlled trial would just have finished and the results would have sat there on a journal and nothing further would have happened. But the ARC is designed to try to prevent that sort of translational gap. It's designed to try to help get these kind of findings into the public domain and changing how we deliver care. And this is where the Finch implementation study comes in. And really, it's asking how we can implement this nationally. And you can see from the map just above my head up here, my pen's disappeared, just above my head up here, that we're working in 4 centres: Newcastle upon Tyne, Nottingham, Oxford and London. And we'll be considering a number of questions, but really developing consistent ways of working with care home staff and falls prevention specialists, considering the roles of what we call an Action Falls Collaborative, which is a type of quality improvement collaborative where you bring care home staff and healthcare professionals together to work in a way that makes the best of both sets of professionals' expertise in order to prevent falls. We'll be gathering a lot of information about how to make sure that this initiative sustains. So we want it to continue after this research project is finished, and we will be specifically asking questions about that and making sure that we report the lessons about how to make that happen. And then finally, really taking lessons from all of the above, we'll be developing something called an Adopt and Spread toolkit, so that from the lessons we've learned from these 4 geographically diverse parts of the UK, we can then encourage centres across the whole country to try to adopt this type of approach to falls prevention, evidence-based care coming into practice. So that's my part, talking about care homes and rehabilitation in older people. I hope I've stimulated some interest, and I hope I've triggered some interesting questions in the chat and the Q&A. Please do keep putting your questions in there. I'm now going to hand over to Rebecca Fisher, who is going to take forward the next part of the presentation. So over to Rebecca.
Thank you, Adam. Can I just check that you can see my slides?
We can see both you and your slides.
Oh, that's lovely. Thank you ever so much. So hello, everybody, and welcome to the stroke rehabilitation aspect of this session. I've listed here the speakers, so it's myself, Nikki Hulawara and Lyle Russell, and also other staff members at the University of Nottingham involved in our part of the BICRI theme. There are also key important stakeholders external to the university that I didn't have space to list, but we're certainly going to talk about them as part of our presentation. So the focus of this session is on stroke care, providing stroke rehabilitation in the community, with a particular focus on how we are working with key stakeholders to inform and conduct our research and how it addresses national NHS priorities. And rather than give you lots of slides with words, I'm just going to leave you with these 4 diagrams here, so you can muse on the diagrams while I give you a brief introduction before I pass over to Nikki and Lal. So stroke is a leading cause of adult disability, damaging the brain and affecting movement, cognition, sensation, mood and language. There is a need for improvements in provision of stroke rehabilitation for stroke survivors living in the community so that their recovery can be supported optimally. The focus nationally so far has tended to be on improving hospital-based care. However, length of stay in hospital has dramatically decreased over the last 20 years and certainly recently. And there is evidence that supports the benefits of providing home-based stroke rehabilitation to facilitate recovery from stroke. Stroke is a national priority within the NHS England long-term plan, and there are recommendations for provision of care beyond hospital and higher intensity rehabilitation to be provided. And the research that we're doing within the ARC East Midlands directly addresses some of these priorities. So our research benefits from very close working with key stakeholders, including policymakers. I'm seconded as Rehabilitation and Life After Stroke Workstream Lead with NHS England's Clinical Policy Unit. So I work closely with the National Clinical Director of Stroke, Dr. Deb Lowe, and the National Stroke Programme Lead, Jodie Powell. Priorities of the National Stroke Programme have informed our ARC research. We have key stakeholders working with us to conduct the research, and we are very much working to ensure that priorities from the plan steer what we're trying to achieve in practice. Another example of this work is the Sentinel Stroke National Audit Programme, for which I'm one of the directors. So SNAP, as it's called, collects continuous patient level data from all stroke patients admitted to hospital and transferred to the community. Again, the NHS long-term plan recommends that SNAP describes the quality of care, not just in hospital, but across the whole stroke care pathway. This will require the current SNAP data set to be expanded so that community-based stroke services can be meaningfully included. Again, our research addresses this, as you'll hear from Nikki. All of our studies that we're highlighting also benefit, importantly, from input from stroke survivors and their carers. The Nottingham Stroke Research Partnership Group have been invaluable in shaping and informing the studies at every stage. So lastly from me, you will first hear from Nikki, Dr. Nikki Huluara, who will describe research relating to the implementation of the National Integrated Community Stroke Service, or ICS model. The service is comprised of a multidisciplinary specialist team or integrated teams delivering home-based stroke rehabilitation. This model is informed and builds on previous research funded by Clark, and its implementation of this model across the country is a national priority. You will then hear from Lowell Russell, who will describe research focused on home-based rehabilitation for survivors of stroke living with severe disability. So as you're listening to Nikki and Lowell, please do comment or ask questions in the chat, and hopefully there'll be time to come back to that at the end. And I'll now man the slides and pass over to Nikki. Thank you, everyone.
Thanks, Rebecca. Hello, I'm Nikki Huluara, and I'm here to tell you more about the ICS study. So ICS stands for Integrated Community Stroke Service, which is a model of stroke rehabilitation service provided in the community. Why was it needed? Existing community stroke rehabilitation services provide support aimed at particular groups of stroke survivors. For instance, stroke early supported discharge services accept patients with mild to moderate stroke severity, and they provide rehabilitation for a maximum of 6 weeks. For patients who don't meet these selection criteria or need rehabilitation input for longer, the main support is currently provided through community stroke rehabilitation services. However, our previous research has suggested that stroke survivors' experience of the transition between these services isn't always smooth. For instance, patients may have to wait for months before they get admitted to a community stroke team, or they may be discharged home from hospital without receiving any further rehabilitation. So there are well-recognized gaps in the stroke care pathway for people with more complex needs and people who need rehabilitation for longer, which really calls for a more integrated and better coordinated stroke care provision. You can see the gaps in the pathway there. Next slide, please, Rebecca. Thank you. So to address these issues, the National Integrated Community Stroke Service model has been developed to ensure that all discharged stroke patients, regardless of their disability, are seen in a timely manner by a specialist multidisciplinary rehabilitation team. An ICS specification has been developed by a national group chaired by Rebecca Fisher and set some key quality standards to help guide the implementation of these services on the ground. This model is already adopted in some regions in England, but we still need to understand how these services operate in clinical practice and how best to monitor their function. In collaboration with NHS England and NHS Improvements, we would like to use our research findings to inform the commissioning and implementation of ICS services in England in order to give more patients the opportunity to benefit from specialist rehabilitation. In developing and delivering this study, we have been working closely with a range of stakeholders. We work with 2 ICS services, one in Manchester and one in Northampton, for sharing with us service and patient data information that they collect as part of their routine clinical practice. We also have strong links with senior stakeholders in the National Stroke Audit, and we also work together with PPI representatives. As our study and data analysis progress, we maintain ongoing communication with our stakeholders to provide updates and request feedback. These interactions not only inform the development of our dissemination and impact strategy through appropriate formats, but also offer channels through which we're hoping to make a difference in practice. Our ambition is to develop awareness of how ICS services operate on the ground and draw some key messages regarding the evaluation of ICS services at both regional and national levels. And now I'll hand you over to Lal, who will be telling you more about the HORSE study.
Thanks. So my name's Lal Russell, and I'm going to tell you about the HORSE study, which is home-based rehabilitation for stroke survivors with severe disability. So this research addresses the need for rehabilitation of survivors of stroke who are left with severe disabilities. So stroke is the single largest cause of adult disability in the UK, and approximately 20% of stroke survivors will be classified as severely disabled when they leave hospital. These patients are generally not mobile, often requiring a hoist to transfer from bed to chair. And this level of disability often affects multiple domains such as cognition, communication, and continence, as well as the more obvious physical disabilities. Greater stroke severity is associated with higher levels of need. However, little exists in terms of research regarding what rehabilitation is most beneficial for these patients, how this should be organised, or how it should be delivered once they leave hospital. So providing stroke survivors with specialist rehabilitation following discharge from hospital has been shown to enhance recovery. There is research evidence for the effectiveness of early supported discharge, or ESD, and this is a service delivered by a multidisciplinary team of therapists, nurses, and a doctor that provide intensive home-based rehabilitation for a number of weeks after discharge from hospital. This model of rehabilitation has been shown to be most effective for those stroke patients with mild or moderate disability, but it's unclear what is most effective for those with more complex needs. Therefore, there is little to inform the provision of services for these individuals, and in many areas, services aren't commissioned to meet their rehabilitation needs, and this has created health inequalities, where those who are most disabled are unable to access rehabilitation. So in developing and undertaking this study, we have collaborated extensively with a range of stakeholders, such as our PPIE group, clinicians, academics, as well as stakeholders from Nottingham Integrated Care System and the East Midlands Integrated Stroke Delivery Network. The first phase of this work was a virtual consensus activity with leading experts, including most importantly, those with lived experiences. This resulted in consensus statements regarding the core components of home-based rehabilitation for survivors of stroke with severe disability. These statements highlight the challenges, and there are many, of providing rehabilitation for these individuals in the community. And they're published on BMJ Online and are available on the BICRI website. The next phase of our work explores the challenges to teams on the ground in providing this rehabilitation to severely disabled stroke survivors and strategies used to overcome them. This study has the potential to improve the outcomes and experiences of severely disabled stroke survivors and their carers by informing the provision of services, supporting clinicians in advocating for their patients, and setting expectations for stroke survivors and their carers. Thank you.
Thank you, Nikki and Lal. I'm looking at the chat. I'm not able to open it just yet, but we will continue looking at the chat. So just to summarise this before I go back to Adam. So to conclude, we are working closely with local and national key stakeholders to conduct research that addresses national priorities of the NHS and ultimately will inform improvements in provision of stroke care. These stakeholders include stroke survivors and their carers, and as we've discussed, the National Stroke Programme. In terms of current and next steps, we're working, as Lal's just said, and guided by leads from all 20 of the integrated stroke delivery networks, particularly these Midlands, which have been implemented across the country to facilitate improvements in stroke care. Their feedback and need for guidance and resources iteratively informs our ARC research studies and guides outputs. This aligns with the overall ultimate plan for us all, which is developing community models of equitable stroke rehabilitation for all stroke survivors who need it. And with that, I'm going to go back to Adam. Thank you.
Okay, thanks for that, Rebecca. So next, I'm going to introduce Professor Niro Sirwardena, who's based in Lincoln. And hopefully Niro will be able to, first of all, come on screen and put his slides up. I can't see Niro currently. Here he is, and here are his slides. Niro is going to speak to you about the program of work looking at emergency services, particularly ambulance services. The conversation is continuing in the Q&A section of the Zoom software. So please do keep asking your questions. It will give us a focus for our discussions once we've finished the formal part of the presentation. So over to you, Niro.
Thank you very much, Adam. I hope you can hear me and see me okay, and hope you can see the slides.
And we can also see your slides, yep.
That's wonderful. So thank you very much, everybody, for joining this webinar, and thank you for letting me speak about the ambulance data work stream of BICRE, where we're looking at development and evaluation of novel ambulance service interventions to improve healthcare and outcomes. And I'm speaking on behalf of the various study teams that have been working on these projects. There are three areas that I'm going to talk about. One is a study around the effects of a booklet-based intervention called Hypoglycemia twice to reduce recurrent ambulance attendances for hypoglycemia, or the AMBU-HS2 study. The second study is around use of point-of-care ultrasound in community practice, an interview study. Point-of-care ultrasound, sometimes abbreviated as POCUS. And the final study is researching emergency ambulance calls to care homes, a mixed method study, so that's the REACH study. And here are the teams working on these studies. So these studies are led by the University of Lincoln and the Community and Health Research Unit, which I lead, and we have a number of researchers you can see working on each of these studies. But very importantly, we have partners at East Midlands Ambulance Service, and also patient and public contributors for each of these studies also, as well as other academics from other universities who are very important collaborators in this work. So the first study is the Hypoglycemia twice study. I'm going to tell you a little bit about what we did and what we found. So hypoglycemia is a potentially serious condition where you get lower than normal blood glucose levels in people with diabetes. It's important because, as well as making people feel very unwell, it causes confusion, dizziness, sweating, sometimes loss of consciousness, rarely death. It is very, very common in people with diabetes. And it often results in an ambulance call. And one of the things that we know from research is if an ambulance is called, the chances of an ambulance being called again are very high. Around 1 in 10 call again within a fortnight. It constitutes around 1% of ambulance calls, which doesn't seem large, but over the course of a year, that's around about 100,000 calls across all of the ambulance services in England. And it's very expensive in terms of admissions to hospital and the ambulance attending, and it costs well over £13 million a year. So one way that the ambulance service, working together with patients and staff and academics at the University of Leicester, sought to try and help this was to develop an intervention that the HS2 or Hypoglycemia can strike twice intervention And this consists of ambulance staff providing advice and an information booklet to patients who were seen by ambulance staff for hypoglycemia. And we wanted to find out if the HS2 booklet prevented ambulance attendances for hypoglycemia, to see if care improved and explore how ambulance staff and people with diabetes perceived the intervention. So it wasn't just the booklet, it was the booklet as a prompt for ambulance staff to provide advice on what a hypo was, how to treat it, how to manage it, and to seek advice from people's GPs or community nurses to try and prevent it in future. And so we did a study across the East Midlands, working with East Midlands Ambulance Service, and you can see that that covered all the counties of the East Midlands. And we used a technique called a non-randomized stepped wedge, and also used an interrupted time series design to look at data from patients attended for severe hypoglycemia. We looked at 13 months before the intervention was introduced and 11 months after. And the intervention was introduced in sequence, first in Nottingham and Derbyshire, then in Leicester and Northamptonshire and Rutland, and finally in Lincolnshire. And we also wanted to use this idea of a process evaluation with questionnaires and interviews of staff and patients to see how it worked and what the mechanisms were by which this intervention, if it did work, was working. And what we found, and this was work done by Dr. Vanessa Botan, supported by Professor Graham Law at CARU, analysed the observations of hypoglycemia over the course of this introduction of the intervention in the East Midlands. And we found a significant reduction in the number of recurrent hypoglycemic episodes in the intervention period compared to pre. And you can see in the graph, there's a fall in cases of recurrent hypoglycemia after the intervention was introduced, with where the dotted line is shown. The other thing we want to see was if care improved. And we used this idea of a care bundle, which consists of glucose measurements before and after treatment. And we found that actually the intervention led to improvements in care. We interviewed patients and staff, and Despina Laparidou, one of our researchers, surveyed patients and staff and interviewed them, and found a lot of detailed information around how the intervention was implemented, contextual factors, mechanisms of action and outcomes, and suggestions for improvement. So we found that most ambulance staff reported implementing the booklet, but not all patients received it. There were barriers to implementation. Booklets weren't always available, but there were facilitators like Positive Attitudes of people with diabetes and staff, and a lot of motivation and willingness to self-manage. The intervention was generally positively perceived by patients and staff. There were some negatives around uncertainty about whether the intervention would work, but people with diabetes thought the booklet was a useful reminder. And you can see listed in the middle the suggestions for improvement. So signposting people with diabetes to local resources, different booklets based on characteristics of and types of diabetes, replacing the booklet with an app, and also suggestions about creating booklets for other conditions. So we found that these information booklets and the intervention linked to that, the advice provided by ambulance staff, reduced the number of repeat ambulance attendances significantly. Both staff and patients found the booklet beneficial, particularly for less experienced patients. And since this study, the HS2 booklet has been implemented in East Midlands Ambulance Service and is being considered in other services. The study has been published in Diabetic Medicine and in Biomed Central Emergency Medicine, and we have an economic paper in peer review. It was the subject of an NIHR alert and a really lovely animation produced by NIHR ARC. And Vanessa won the highest quality research award for presentation of the quantitative results, and Despina won another award this year for research making the best use of routine data for the process evaluation. In the POCUS study, this is an interview study looking at introduction of point-of-care ultrasound, which is available and rapidly developing as a technology. Point-of-care ultrasound is a handheld ultrasound device which could help prioritize initial treatment and enable appropriate patient conveyance when it's used in the community, either by paramedics or other ambulance staff or GPs. But there isn't much evidence around its pre-hospital use and impact, and further work is needed. So we wanted to explore the views of practitioners who used ultrasound in practice on its potential role and the facilitators associated with its use. So we did a qualitative study using online interviews and recruited through social media and snowballing. We used a type of analysis called framework, and Dr. Joseph Akanaway, who led the interviews in this study, interviewed 16 practitioners, and those included GPs, paramedics, emergency physicians. What did he find? He found that there were important facilitators of implementation of POCUS, so things like resource requirements, cheap working equipment available with training for practitioners and ongoing support, proper governance, guidelines and quality assurance around use of the technique. And although many of the interviewees who are using point-of-care ultrasound felt that it was a very positive support to their clinical management, more evidence was felt to be needed to support these perceptions. Many of the practitioners using it found it straightforward and easy to use, but there were some concerns around the unintended consequences of using point-of-care ultrasound. Particularly, there were either false positive or negative results that might have led to the wrong conclusions. And in terms of workforce, there are important workforce considerations around who should be using it and how they should be trained, who should be training. And so all of these suggested that point-of-care ultrasound is potentially useful for care process and pathways, but we need to think carefully about facilitators and barriers to its use. The final study I'm going to tell you briefly about is a study in progress called REACH, or Researching Emergency Ambulance Calls to Care Homes. And we know, and Adam's mentioned this in the previous talk, that care homes are an important place of residence, particularly for older people. Ambulance calls to care homes are really quite common, costly. Patients are often conveyed to hospital, and it's thought that this is preventable in half the cases. But this study isn't just about transportation to hospital and trying to prevent it. What we're trying to do is to try and figure out how to improve the quality of care and outcomes for people who have emergencies in care homes. And that's not really just about preventing admissions, although sometimes that's important. We know that 30 out of 100 residents each year are transported to the emergency department. Twice the number in care homes compared to those living in the community end up in A&E, and half of those who are transported to A&E end up in hospital. And we know how expensive hospitalization is, and it can be detrimental, particularly to older people who are confused and who might be immobile and exposed to various problems in hospital. So we wanted to evaluate the demographic and clinical predictors of conveyance to hospital following an emergency call, and explore how outcomes for care home residents with emergency conditions and for the staff involved can be improved. And what we're doing in this study is to systematically review all of the research investigating effective interventions to improve outcomes and experiences of emergency care in care homes. We want to describe care home approaches, policies and protocols for emergencies, so how they're responding to emergencies in terms of their written protocols, but also investigating factors that predict ambulance attendance and conveyance. And then, as well as looking at the policies and protocols, explore what happens in reality through these interviews of residents, relatives and staff, and try and understand how we can improve outcomes and care. And what we're going to do at the end is to prioritise and recommend interventions that do or are likely to work. So thank you very much indeed for listening and for your comments and questions. I'm just going to unshare that.
So thank you for that excellent summary, Nero. If I can ask the colleagues that are presenting to come back on camera now, hopefully they've finished their Watsits or their cup of soups or whatever they're having for lunch. And we do have a few kind of questions in the chat. Please do keep the questions coming. We've got enough time to answer a few questions. So the first one actually is for you, Nero, and it's about how, I mean, they were asked specifically about the AMBU-HS2 study, but I think it's a more general question when you're working with ambulance staff that they're very work pressurized at the moment, more so since the pandemic. So how do you engage ambulance staff and get them, connected with research when they're under so much pressure?
Yeah, that's a great question. So this study was interesting insofar as the intervention and its implementation was actually designed by the ambulance service and ambulance staff. So it was led by them, and they developed the idea of the leaflet together with patients and academics at Leicester, and rolled it out with staff using champions, using education. The research with the ambulance staff was then easier because what we did was use routine data to analyze the effect of the intervention. So we didn't ask the ambulance staff to do anything in particular because, as you say, they're extremely busy. And so although many more ambulance staff are getting involved with research studies, this didn't involve them doing anything in particular. We use routine data, analyze that, and then we interviewed staff, and they were very happy to be interviewed, some of them, for this study. In terms of engaging them, we have research paramedics at East Midlands Ambulance Service. One of my colleagues, Greg Whitley, who's a postdoc at the University of Lincoln, also works at East Midlands Ambulance Service. And we have a great team at EMAS who work in research. And so I think they've been very helpful. But there's also senior support from the medical team and the other teams at EMAS that help to engage staff, and we work very closely with them.
So it's kind of core principles there really of sort of getting people on the inside to work with you in research and actually empowering them to lead the research agenda for themselves. And that's something that we're working hard with in the care home sector as part of the living lab model in care homes, which we're piloting in Nottinghamshire and Derbyshire, to try to get care homes, to try to work with care homes to understand what they need from research and help to encourage them to lead for for themselves, and that's very powerful when they do. There's a couple of questions which I'll just take around the care home study, and there's one that I can give an answer that I'm quite proud of, and one that I can give an answer that I'm slightly less proud of, so I might as well take them as a block. And the first one is, how do we overcome the challenges of engaging care home staff during the COVID-19 lockdown? And I think that the work that Fiona Marshall, I can see that Fiona's on the call in the audience, Fiona Marshall was our lead researcher for this, and she did exemplary work at the height of the COVID pandemic in terms of not just finding care homes that would participate in research, but in terms of finding the right types of care homes for this study. And one of the problems with care homes is that it's often the same people that come forward, the same organizations that come forward for every single study. And I know that some of the care homes I work with now are the same care homes that I was working with when I started doing my PhD in the care home sector back in 2008. And for this study, we weren't really interested, well, we were very interested in them, but we weren't particularly interested in learning from the people that are already, atypical in terms of the relationships they have with researchers in the NHS. We wanted to meet with people that were maybe a bit more removed from that type of support. And so what Fiona did was she started with the people we knew, and then used networking, a kind of snowballing approach, to get them to signpost her to other colleagues in the care home sector that hadn't been involved in research, hadn't been involved in development work with the NHS, and were really a bit more isolated, so she could understand how those organisations navigated the pandemic. And through that kind of combination of introductions and persistence, she got a really great sample of care home staff that gave us a real kind of diversity of experience. The second question for me was around how we engage patient and public involvement in the care home research. And I think that's something that we struggled more with during the pandemic, if I'm completely honest. We did have some patient and public involvement, but really it was about going back to the people that we'd always spoken to and always worked with, and asking their opinions about the work we were doing and getting them to consult on the work that we were doing. And I think in retrospect, if there's one thing that we might have done slightly differently, it would have been trying to replicate some of those snowball approaches we did for care home managers, with relatives and residents. But I'm pleased that we managed to get some work done, and I'm pleased that we managed to get it done with people that otherwise would have been hidden from researchers and service designers. So I think, massive commendation and thanks to Fiona for all the effort that she put in there. So Lau, we have a question for you, and it was one of the questions I had for you. So this person stole my thunder. They're anonymous, but they're asking really good questions. And it says, how do you plan to progress what stroke survivors said was important to them?
So I think that's on the back of the question I answered earlier, which was just around what we've been doing. So we've done quite a lot. We've been really blessed with great support from our stroke survivors and from our carers. My background's a physiotherapist, so that's where this project really was sort of triggered a very long time ago around patient feedback and what they wanted, and that's where some of this project has been driven from. So that's really where it's come from. And then we are very lucky to have the Nottingham Stroke Research Partnership Group, which is sort of manned by Helen Taylor, who's probably in our audience, hopefully. And they are phenomenal. They give us huge amounts of support and also critique. They will say that study's not worth it. How, what are you looking at? Why is this? What's the benefit for patients? Where are carers in this? And they're very, very a strong, assertive voice, which is really what we need as researchers and clinicians. But they've been great. So our first work package was the one I talked about, which was the consensus. And we got sort of a list of all these statements that people were coming up with. And then our second package, which we're currently working through at the minute, has been looking at on the ground, how do teams deliver this? And what we did is we went back to our patients and carers in between times and said, right, out of all these statements, there's lots here. What do you want us to focus on? What is most important to you? And we did a sort of priority setting with them around what they'd really like us to look at. And we took 4 of those headings forwards into exploration with teams on the ground and see what they could do for patients and carers.
So I have a kind of follow-up question, which is related but separate, and you don't necessarily have to take this one yourself, Lau. You can bounce it to one of your colleagues. But so you're obviously doing some very intensive work in terms of developing some very grounded recommendations about what needs to be put in place. I guess my question is how you then square this question at the Finch IMP group are doing, which is how you go from proving something at a regional level or a few, focused areas to actually delivering it across the country at scale and pace. So do you have any sense of how this goes from being something which is a translational piece of research that you're doing just now into something that would be widely implemented? So I wonder if you have any thoughts on that. I see Rebecca smiling, so you can go first, Lyle, but if you get stuck, Rebecca.
I'm absolutely handing over to somebody who started this. I mean, what teams are saying when we talk about this is, well, where's the new funding? Where's the new intervention? And it isn't to see it as a new thing. We looked at these statements, consensus statements, and there's lots of crossover with the ESD work that Rebecca has done. So a lot of those skills are already there within teams, and we're looking for ways in which workarounds, strategies, how do people who are delivering it now do it? Because it's happening. Some teams are doing this, and it's not just in the East Midlands. So we're talking to teams, in other areas. So it is happening. It's trying to empower people to work out how can we use our resources really flexibly, and how can we be very patient-centered about how we do that, because not all of them need the same thing. Go on, Rebecca.
Yeah, no, and I think it's a really good point, Adam, and I don't think there's a sort of straightforward line between where research and the quality improvement directly related to the research stops, and how you then link into other quality improvement activities and national activities that are happening. And certainly we're blessed in our group, I use that word, with myself, who sort of is on both camps. So I would say the way that we're doing that, as I said, is in linking in with the integrated stroke delivery networks and national programs, of which there are a couple particularly focused on stroke rehabilitation, to make sure we're feeding in information where appropriate, and then letting them in their world deal with the scale of quality improvement, but just influencing this and steering that to make sure it's informed by what we're finding on a more detailed level. And then just briefly, Fiona's popped up in the chat about vocational rehab. That is definitely a national priority, Fiona, not just within stroke, but across rehabilitation. So again, very much linking what's happening within Nottingham, so Cape Radford, etc., and trying to make sure that evidence influences policy and practice.
So Fiona, not just in charge of the excellent research work, but also in charge of some of the excellent questions as well. Nero, I just wanted to ask you a question. It was, interesting, isn't it, the work around ambulance service and care homes. And one of the things that care home managers and staff often say to me is that the relationship with ambulance staff can be quite unequal. So they feel that when they call a member of ambulance staff, the sort of the power base is very much in favour of the ambulance staff, and the care home staff don't feel they have as much voice when it comes to negotiating maybe whether their resident goes to hospital or stays in the care home. I wonder if you've got any reflections from the work that you've been doing about how we make those discussions more equal and give care home staff possibly more voice or say in what happens with residents that they know very well.
Wow, that's really interesting. So I didn't know that, Adam, and the lovely thing about being a researcher is there's so much that I don't know. We've just, when I say we, Despina Leparadou has just undertaken 15 interviews with ambulance staff, and we're about to do the same with care home staff and patients and relatives in care homes, or residents and relatives, I should say. And I think to try and understand those discussions and negotiations is really important. We published a piece of work in a journal called Age and Aging on the experiences of residents and relatives on emergencies in care homes. And what we found from that systematic review and metasynthesis of the literature is that experiences of residents and relatives are very, very variable, and the resources, ways of working of care home staff and ambulance staff are very, very varied, and sometimes not so great in terms of communication and so on. And I think one of the things that we found in other areas of work is this link between professional groups, whether it's the care homes and ambulance services, or the ambulance services and ED or primary care, are really critical to good outcomes for patients. But there are many pressures on how people are managed that care home staff talk about. And it's not just ambulance services, it's also primary care, the residents themselves, their relatives, advanced directives, and their own policies, and of course fear of consequences of not acting correctly. So there are many pressures on care homes, and hopefully this study will draw some additional ones out in terms of the relationship of ambulance services and care homes.
Yeah, I mean, it's massively valuable work, Miro. It's great that we're able to do it. So we're just coming to the end of our time. There is one other question, which is, did we do work into home care in COVID? And I owe the audience an apology. We did do work into home care in COVID, and I neglected to include it in my first slide. That work is just being written up as we speak. So if you keep a close eye on the ARC website and the ARC Twitter feed, you'll see that work as it becomes published, and it will be a delight to share that with you as it becomes available. That work was led by Professor Pip Logan and her team. We've run out of time. Thank you for your engagement, your support through this. Thank you for your excellent questions. I hope that you are as excited by the work that we're able to do as we are to be doing it. And we hope maybe to come back in future and tell you more about how this work has developed. There are a number of ARC webinars coming up over the coming months. The next one is, I believe, later in May, and it's the Data to Health webinar, which is talking about how we use big data to improve healthcare. And I would really encourage you all to dial in for that one, and keep an eye on the ARC Twitter feed and website for other up and coming webinars. Thank you very much for your time. Thank you to all your speakers, all our speakers, and I hope to be presenting to you all again in the future. Goodbye.